I'm Busi or Busi Nkosi from the Africa Health Research Institute in South Africa. The title of the presentation is Addressing Vulnerability and Engaging Agents in Research, a research ethic case study on HIV prevention for young girls in KwaZulu-Natal. During the presentation, I am going to share insights on linking empirical research ethics with an implementation research case study in South Africa. The REACH study was linked to the DREAMS implementation study. DREAMS means standing for Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe Women. The aim of the study was to evaluate a comprehensive package of interventions which was implemented by 11 partners in health facilities and in community settings in Umkhanyakude district. The specific objectives were to measure the impact of the DREAMS intervention on HIV incidence in adolescent girls and young women and their male partners, to identify pathways for DREAMS' effect on health, education, and social well-being of adolescent girls and young women, and to explore the process and experience of DREAMS in the community. The study was led by Miriam Shamanesh, Natsai Chimbindi, and Thembi Zoom. So coming to REACH, the aim of REACH or the focus were to understand dilemmas arising post-approval in studies involving vulnerable populations, how to better support research teams in responding to complex and structural needs encountered in research in low and middle-income countries, and to consider the implications for research ethics guidelines on vulnerability and conceptual accounts of vulnerability in research. Because DREAMS offered a range of services beyond the narrow biomedical interventions and also evaluated these services within low-resource health systems, it provided valuable opportunities to understand the ethical realities of responding to complex health and social needs through research. Now we are going to look at the background and methods. The study was conducted in the province of KwaZulu-Natal in Umkhanyakude district. The nearest big city is Durban, and the demographic profile is shown at the top of the box. In terms of the socio-economic and political context, most of the population in the district depend on subsistence agriculture and mining, as the district is largely rural. Although South Africa is a democratic country, the district is dominated by patriarchy and tribal or traditional structures, which inform and shape the local value systems and norms. So the district is bordered by Swaziland and Mozambique. In terms of the disease burden, HIV prevalence is high, estimated at 30%. It is higher among young women compared to young men. In 2016, the prevalence was 6% for young men and 19% for young women, respectively. There are high rates of teenage pregnancy and non-communicable diseases among adults, as well as MDR-TB. Now, in terms of the health system, there are five district hospitals, and all were originally missionary hospitals and were nationalized around 1980. So despite the changes in the demographic population, no new hospital has been built since 1980. The hospital doctors are generalists. There are 52 provincial clinics which are staffed with primary healthcare nurses. Most clinics are visited twice by medical and paramedic staff once a month, and there are 30 mobile clinic points. So the district is prone to cross-border epidemics, as shown that it's bordered by Swaziland and Mozambique, and especially malaria and cross-border patient flow, leading to unbudgeted health expenditure and adverse patient outcomes. Only 17% of the population is uninsured and often depend on the public health system. So the specific research questions for the REACH case study were: how do research participants and community members perceive their own situation with respect to vulnerability and agency, and what are their experiences and expectations of research? The second one was: what ethical challenges do researchers face when implementing comprehensive programs like DREAMS across deprived health systems involving vulnerable populations? And lastly, what ethical considerations arise in studies which deliberately target one vulnerable group, and in this case, the adolescent girls and young women, to the exclusion of others in need? In terms of the method, this was a qualitative case study design. We used purposive and snowball sampling techniques to recruit information-rich case participants in regards to the research question. Participants were identified through referrals and networks, and we sought those that were enrolled in the DREAMS study and with experience in research and ethics, as well as the community views on vulnerability and agency. The interviews were conducted in English or the local language isiZulu, and they were audio taped, and they lasted between 45 minutes to 2 hours. In total, we recruited 77 participants. There were 5 refusals, and the reasons were lack of time or lack of interest to participate in the study. So the table shows the data collection method and the sample. Of the 77 participants, 65 sat in group discussions, and these involved adolescent girls and young women, and were divided into 2 groups: those that were 10 to 14 years old or 18 to 24 years old. And we also recruited their counterparts, or males 10 to 14 years and 18 to 24 years old respectively. Other participants included caregivers of the adolescent girls and young women enrolled in the project, the community advisory board members, community caregivers, frontline researchers, and public engagement officers. 9 participants sat in the in-depth interviews, and these included community stakeholders and researchers or investigators and implementing partners. And 3 key informant interviews were conducted with the ethics committee members. In terms of the analysis, we had regular team meetings and reflections on the data. including discussions of language and meaning, and we sought to understand the nuances and the context and experiences of participants in regards to vulnerability and agency. We use an open manual iterative coding during data collection and after data collection. We use the thematic framework analysis to analyze the data, and themes were determined by the study aims and content of the interview guides and inductive development of codes as they emerged from the data. Now we are going to share the results. So the results describe the intersection of complex structural vulnerability of daily living for adolescent girls and young women, their families, and other community members in the study setting. We also describe the expectations surrounding research in responding to the complex health and social needs. And thirdly, we describe the ethical dilemmas and moral distress faced by researchers in the study setting. So we are going to look at the structural vulnerabilities and constraint agency. The study showed that the sources of vulnerability in daily life are intersectional, structural, and relational. For example, we found that gender-based violence was widespread and was concentrated among women and young girls, especially those living in poverty. I'm going to share a quote from one of the public engagement officers. The situation with young people is very sad. They are easy target when it comes to abuse. They or perpetrators are usually older males. They target children from poor households and give them as little as 20 to 100 rands, which is the equivalent of 1 to 7 US dollars. What makes this upsetting is that the individuals who commit these acts should be protecting these young people. We also found that vulnerability was relational. In some instances, those who are meant to protect the vulnerable sometimes hurt them or shielded the perpetrator. And this was often linked to whether the perpetrator was the breadwinner or protecting the image of the family and not disclosing or exposing the shame of the family. So as one implementing partner stated, I remember there was a family last year where we heard that an 11-year-old was pregnant and the perpetrator was one of the adult males who was a customer at this shipping or tavern. So when we got there, the grandmother was very defensive, asking, "Why are you here? Why?" So these raise questions about assuming that families are a sanctuary or they provide provision for younger girls, when in some instances they are a source of where these young girls are hurt or are exploited. Our study also showed that young women did not see themselves as victims, but they demonstrated agency. However, this was constrained by the lack of support, often by those in power. As they shared during the focus group discussion, as young people, we have talents that we can use to improve our lives. Like we can start our own businesses because we can do handcrafts. Like my peers, participants 5 and 6, they can braid people's hair. So they need people who can support them to expand their business. But if you don't have connections with those in power, like counselors, you can voice your concerns, but you will not get support. Now coming to the second part of the results and looking at the researchers' experiences and ethical challenges. So one of the challenges was the unintended harms. The participants felt that targeting one vulnerable group was seen as unfairly excluding other groups, causing backlash. Interviews with the community members and community advisory board reported that they were inundated with the questions, why are we being left? And because the study was conducted in a setting where most people lived in poverty and facing similar vulnerabilities, caregivers of young girls below 10 wondered why their children were excluded from the program which would benefit them. There were also concerns about the target population, those between 10 to 24 years being excluded. However, this had to do with the logistics and the target number that the program could enroll, but still people felt excluded. And the exclusion of young boys raised animated discussions, and the exclusion of the elderly, who participants felt in some respects they were more vulnerable than the target population or the young people aged 10 to 24 years old. So, as noted that the exclusion of young boys had animated discussions, it raised the question on the advocacy paradox. Participants raised concern about focusing on young girls and whether this might the solution to reversing discrimination. And one of the issues they raised was focusing on young girls, particularly on healthy sexual behaviors, put pressure on the young girls. For example, they are the ones who must negotiate the use of the condoms. Whereas if boys were included in the program, it would alleviate that pressure because both young girls and boys would be empowered in that regard. And during the focus group, one of the public engagement officers stated, women cannot be empowered to have safer sex without also taking into consideration the behavior of men. And this was critical, particularly given that the area is patriarchal and dominated by tribal structures and norms. So, by focusing on young girls, are we creating a backlash against girls, or are we introducing new injustices towards young boys? So these are some of the questions that were. The findings also showed that participants and community members often saw research as a source of care and expected research to address wider health and social needs. For example, members in the community who join or who participate in RE research are often linked to care, and they get referral to health facilities with our clinical staff, and so they prefer this to public health facility staff. So one of the CAP members noted, now a lot of people present at the research clinics just for screening without any sickness, just wanting to know about their health and well-being. Research in the community has encouraged a lot of people to test for HIV. And then in terms of the social needs, many of the households were food insecure, and so they saw participation in research as an opportunity to help make ends meet. As discussions with the public engagement participants stated, I think that for poorest and indigent households, they enroll their participants not because they understand the study, but because of the incentives in form of 50 rand vouchers or the equivalent of $50. When they hear about the vouchers, they are calculating, okay, I will be able to buy something to eat or make ends meet. We also found that if research does not provide sufficient direct benefit, it can be felt as a burden and even exploitative. And this was felt more by frontline researchers who had to witness poverty and hunger, but continue to with the interviews or ask the participants research-related questions. And so some reflected on this experience. So it's like you're exploiting me every time you want me to give you information, but you do not give anything back. I do not benefit. So they were expressing this from the lens of the community members. And then one stated, it's onerous having to respond to one and the same questions repeatedly, questions which people do not find helpful. The study also showed the limitations or limits to the referral services and approaches to ancillary care duties in resource-limited health systems. The first quote, in the interest of time, speaks to the challenges in the referral system. The Research Institute has a referral unit and coordinates and refer participants to government institutions. However, this was a source of frustration for many frontline researchers. So I'm going to speak more to the second quote, which has to do with referring participants who or members who experience gender-based violence. Frontline researchers could not trust these services because they were either unresponsive or exacerbated participants' vulnerabilities, and they also had concerns for their own safety. So I'm going to read the quote. The standard operating procedure states you might be required to go and testify in court. In the event the case may be taken to court, it's discouraging for us to report these issues because we also live in the same community. So if I go and testify against a family member in a child rape case, for instance, you think, am I still going to be able to go back and be accepted in that community? And this was complicated by these tribal structures because the norm is to report these cases to the local chief, often without any regard for the law. So this put the frontline researchers in a very difficult position. We found that the burden of responding to complex vulnerabilities and needs of participants falls largely to frontline researchers and other non-clinical staff, which cause moral distress. Often these staff did not have the power to effect any change. I'm going to read the quotes. But what can you do? You cannot just ignore people's plight like that. These things leave me helpless and I wish I could do more. That's from an in-depth interview with the investigator. And the second one is from the implementing partner. So sometimes you can feel that, you know what, I am hitting the wall, but you just keep on trying and trying and trying. So that is what is most said about the kids. Like helping them is a challenge, you see. That is why I think for them it requires patience and time. Um, So moral distress was not only experienced by the frontline staff, but also non-clinical staff felt a strong duty to respond and distress in not being able to help. My colleagues have said a lot about the challenges that we face. There is nothing as painful as wishing you could do something for the community members, but you cannot. We are human. Now we're going to look into the conclusions and reflect. The research aimed at addressing biomedical and social vulnerability is important for building evidence for effective interventions. Research targeting adolescent girls and young women remains critical, but it can result in backlash when other vulnerable populations or people are left out. In South Africa, there is a strong focus on young girls' empowerment, but young women's agents and vulnerability are linked and deeply relational, depending on support by family and others, and depending on engagement of young men. Others can also be the source of risk, like family members, as shown. Research is seen by participants and community as a source of help and response to needs beyond narrower research objectives. The referral to services approach to link care needs in research is challenging in a fragile health system with few or overwhelmed social services. This puts frontline research and staff in the position of feeling they should respond to wider health and social needs, but causing distress when responses feel inadequate. Our final thoughts for reflections. The study raises a number of questions, and one being, how can we better support frontline researchers who bear witness to illness, poverty, suffering, and violence? Do frontline researchers have the tools and support to respond? So there is a need to better recognize moral emotions in research ethics. And finally, relationships are at the heart of our moral obligations on frontline of health systems. Finally, thank you, and we would like to acknowledge the research assistants Sakele Kulu and Nondumiso Dlamini, all the study participants who shared their experiences and knowledge, the project team in South Africa, Maureen Kelly and Janet Seeley, and we would like to thank the Wellcome Trust for funding.